Okay, ready? Good morning, everyone. It's so nice to see you today. I'm Gigi El-Bayoumi, a professor of medicine, and just changed from GW to Georgetown. So that's where I'm going to be, or I am, I should say, founding director of the Rodham Institute, which is dedicated to improving health equity right here in Washington, D.C. But I am also, not but, and I am also a breastie of 18 years. And if you can believe it, during COVID, I had my second cancer of kidney cancer. I think that the discussion that we're about to have on health equity is so important. But as a physician, as well as somebody who works in the community, we have about 160 community partners. Allow me to just make some observations based on the previous panel under the leadership and moderation of Miss Ricky Farley, who I admire so much. One of the things that has happened that I really think needs to be incorporated into clinical trials, into screenings, into a whole lot of things, is that finally the medical and scientific community has realized that stress is a carcinogen, something that we've always known, right? My particular breast cancer was caused by my ex-husband. And I will say this, not just because of the stress, but I missed 3 years worth of mammograms. And that's another aspect. If you have any friend who's going through a stressful time, male or female, remind them about their screenings. Because when you're in it, you're just so distracted. You know, I was talking with one of my friends here who was on the panel. I don't think we recognize what stress does. Lack of sleep, working nights, all of these aspects that are really the social determinants of health, social determinants of education, and social determinants of employment. These things, I will guarantee you, as physicians and other clinicians, never get asked about. Yet we know, and our understanding, did you know we've got 12 circadian clocks? Of course, the master clock is in our brains, but there's a lot that can be disrupted and disrupted by a number of factors. The genetics aspect is very important, and also to enroll people in clinical trials or to have people seen by preventative oncologists or preventative cardiologists. It turns out through a study at my previous institution, looking at Black versus white women, Black women want genetic testing at a higher rate than white women, and yet they are not offered it, right, at the same level. I think another aspect when we're taking care of people is the aspect of competing priorities. We've talked about, multi-generational households. We've talked about stress. We've talked about jobs. And if we don't look for those aspects and talk about them at the front end, then we've lost, the game. I mean, we will be always running behind. Finally, with women, I just want to say we do a lot of self-censorship, and this has been studied over and over again. I can tell you when I found my breast lump, I said, is this what I think it is? And for a few minutes, I really hesitated on pursuing what it could be. And we do that. We have these dialogues. Sometimes we talk to our friends. No, you'll be fine. And so that inner voice really needs to be listened to. Finally, I would say that clinical trials are not just for treatment. Down the road at the NIH, they have clinical trials for people who've got a strong family history of cancer or anything else. And finally, in closing, one of the blind spots for physicians and clinicians when it comes to cancer is looking for other cancers. Women or people who've had radiation are at higher risk for lymphoma. Breast cancer survivors, such as myself, are at increased risk for colon cancer. I have to have my colonoscopy not every 10 years, but every 5 years. Okay? Many physicians, I'll just say it, don't necessarily know these things. And so it's very important that, and also Herceptin, which I was lucky enough to get because it was just approved by the FDA a month before, that can be associated with heart issues. So it's very, very important that we demand that we see people who know what they're doing. Yes, we can advocate, but look, when I had cancer, I was in a fog. I mean, really, who can think about everything? That's why a buddy, a church partner where they've got resources and health ministries, that becomes really key. We cannot shoulder the burden when we ourselves are going through a divorce and a cancer and all these things at the same time. So, buddies and looking out for each other is very important. So I'm looking forward to this robust discussion that's going to happen. Health equity, the devil is in the details, and we really have to dive in. Thank you.
Dr. Gigi, and this is the one time I get to move the microphone up. So, all right. Well, that was so robust with Ricky. I think we all needed a few minutes just to decompress from all of that rich information that she had. So, can we give Ricky and that panel another round of applause? It was just fantastic. So, we've got big shoes to fill, but I know we've got some powerful people that can do it. Health equity is defined as the state in which everyone has a fair and just opportunity to attain their highest level of health. At face value, this definition reflects the highest ideals regarding health equity. However, when filtered through the lens of health literacy and cultural competency, the desire to attain health equity and the reality of achieving it remain far apart. For health equity to be achieved, the above definition must be both accepted and understood by all. Additionally, the understanding must go beyond defining health equity, but must include literacy, advocacy, competency, transparency, and trust. The need for health equity is apparent. However, understanding it has some challenges to overcome. Recently, BDO polled its audience and asked if they knew what health equity means. Of the 1,200 plus responses, only 37.4% responded that they knew what it meant. This poll represents that there is a gap in the public's understanding of health equity. So, we have assembled a top-notch panel of professionals to discuss health equity and help us get closer to both defining and achieving it. So let's get started. In no particular order, our first panelist is Dr. Drew Atu. He is the president of Global Vaccines at Merck. Next, we have there Mr. Rod Cotton. He's the senior vice president, head of strategy and transformation at Roche Diagnostics. We also have Dr. Christina Harris. She is the chief health equity officer at Cedars-Sinai. And we have my 3-year love affair with Dr. Millicent Gorman, CEO of the Alliance for Women's Health and Prevention. And finally, we have Paige Bingham. She's the National Program Director of Close the Gap, who graciously accepted and stepped up for Sam Conaway, who had some traveling difficulties getting here. Welcome to you all, and thank you for being here. So let's get started. Our first question is this. So I talked about the poll that we did with our audience, that nearly 2/3 of respondents either didn't know or were unsure what health equity was. For each panelist, when you hear the words health equity, what does that mean to you? Dr. Atu?
Sure. Well, good morning, good afternoon, good evening, and Ellis, thank you for moderating. And I'm here representing Merck Vaccines and the work that we do to discover, develop medicines and vaccines. So when I think about health equity, I like the definition that you gave, but I'm going to also tie it to agency and the mere notion that health equity is the ability to ensure that everyone of every age, everywhere, who wants access to healthcare and medicines and vaccines can get it. Very simple.
Dr. Harris?
I'll add to that. I'm a primary care physician, and when I think about health equity, I think about, everything that we were trained to do in medicine. It is really just fundamentally patient-centered care. It is expanding that definition, but it's truly giving the patient what they need and recognizing, like, I can't do the same thing for every patient. We know that fundamentally, but the questions we have to ask and the things we need to think about are expanded when we think about health equity. So it's not brand new. It's what physicians are trained for. It's what we all do while we're in healthcare. It's just expanding what we mean when we think about patient-centered care.
Yeah, we launched the first COVID test in March of 2020, and I had to confront that, what health equity was in that moment. And for me, it's about everybody having the opportunity to realize their full health potential. And someone cleverly said that health equity isn't treating everyone equally, it's giving everyone what they need. And we know that if people don't get what they need from a health perspective, three things usually happen. One, there's a decrease in lives and a decrease in quality of lives. Also, there's an increase in disease incidence rate. And then lastly, there's a decrease in access to healthcare. And all of these really can affect people's lives.
It also means diminishing and eventually eliminating obstacles that prevent people from accessing high quality preventive care. And with the Alliance for Women's Health and Prevention, what we're trying to do is to make sure we have that diversity within our board and the diversity on our advisory council to make sure that we can lend those kinds of access to preventive health care.
I would add in, loved all these responses. The definitions vary by every individual you talk to. I think that's where we always start is the question you're asking us right now. What does health equity mean to you? And the visual, I'm a visual learner, I always love is equality, equal blocks, equity, it varies. And are we doing that when we deliver medicine? When we deliver clinical care, when we deliver heartfelt interventions, do we go ahead and give more to some because they need it and recognize others are maybe already blessed, graced, or endowed unjustly with receiving access at a very high rate? So that's the piece of how are we intervening to meet people where they're at.
Those are all fantastic answers. And I think it represents, like we talked about, is the varying nature of health equity. So we're going to try to boil it down a little bit more with this panel. So I think too often we talk about health equity, it's presented from the standpoint of what's wrong in healthcare, right? We have this kind of negative thing that, okay, something's wrong with healthcare, so we got to get more health equity. From your vantage point, how do you see health equity? And more importantly, what should Black Americans be excited about with health equity today and in the future?
What I would say is that one of the things to be excited about is the fact that there's new technology. When you think about telemedicine, when you think about wearables, when you think about apps on your watch or your phone, that provides more access to Black Americans. And so I get really excited about that. And then Rashima said it today, earlier today, there's more public funding available. Post-COVID, there's a lot of funding available, and I think that's helpful. I'm on the board of a $3 billion health system in Indianapolis, and as a Black American and a hospital board member, what excites me too is that many providers now, they are actually paying more attention to the relevancy of different cultural aspects, really, and recognizing and acknowledging the historical and cultural differences that shape the perceptions of health by Black Americans. And they're taking these factors and they're now using that combined with diversity, equity, inclusion training to tailor a health care plan that's culturally appropriate. And are we there yet? Absolutely not. But they're making progress. They realize that to get the overall health results they need, they've got to do this.
You know, we know how to do this, right? So I think we should be encouraged that There is a proof of concept. Again, we've done this, we know the results. It's encouraging, but we have a lot of work to do. And so Rod mentioned the onset of COVID and the impact that had on our community. So if you recall, when COVID vaccines were being released, Black and Latino communities lagged way behind in terms of vaccination rates. And once all of us became aware of that, constituencies, advocacy groups, the federal government, national government, we took action. And what did we do? We, instead of getting people vaccinated or seeking to get people vaccinated in stadiums and mass vaccination centers, we went to faith communities, we went to schools, we did picnics, we went to the barbershops and the beauty salons. And what happened? We saw vaccination rates in the Black and Latino community go up. And in fact, in the Latino community, the vaccination rates went higher than the white community. So we know what to do. When we pull in advocacy groups, groups like Black doctors, we have trusted voices. So in the earlier panel, we heard, you need to bring people who can speak in a language that resonates and is trusted. So again, we know what to do. We've seen it work before, but we can't let everything we learned in the pandemic go by. We need to build on that as well.
I think one of the things that's important to the Alliance for Women's Health and Prevention is that we have those trusted voices out there. I was the executive director for the National Black Nurses Association for 27 years. And so we worked with the pharma industry, particularly during COVID, to try to get, first of all, more of our people, more people of color into clinical trials. And then second of all, to get more of them, including the nurses, because there was hesitancy, to make sure that they also receive their COVID shots. But as important to that is what someone said earlier about getting more Black doctors and nurses and researchers and PAs trained to provide the care that we all need. It's an access issue. So we're real hopeful, particularly for women and girls. I'm also on the board of Simmons University, which is all women's school in Boston. And I'm going to do a shout out to one of the other women's schools, Spelman. We need to collaborate with these organizations, with these educational institutions to make sure that we educate and train more healthcare providers to provide the access to care that we all need, and particularly women and girls.
I'll just add, I know what I'm excited about. I'm excited that after decades of talking about disparities and another study, 3 times more likely pick a disease, and watching all of these disparities over the years get bigger, gaps, right? Because one would think when you know better, you do better. That's not been where we are. Health disparities have been getting worse and worse and worse. I'm excited that we are finally at a time of action. And this is not to say that there have not been people who have been fighting this battle for a very long time and coming up with, active and intentional programs. But I think I'm excited about the fact that hospitals, payers, all understand that this is not just about that nonprofit trying to do the good work. It is all of our jobs, right? And that momentum has been truly, truly incredible. And I think, thinking about COVID and the power of what we could achieve when we came together is all the proof we need, right? So no more inaction.
I'm excited by Black leadership. And I say that because it did not save us from the disparate death rate that happened during COVID by any means, but it has created hope for the future. I love how this question was written because it was really inspiring us all to think about beyond all the harm that we're trying to serve and solve. More importantly, what is happening positive. I would say the Divine Nine, the fact that many have exceeded their centurion birthday, that they are coming into a legacy status, that they have individuals that are really in need of the rising risk, high risk care that many of us are associated with in terms of helping treat and prolong life. Here we are in DC, so we have the Vice President, Kamala Harris, as a great signal that there is a next generation, and it is inspiring, and I'm inspired by that. I should say we're in Pittsburgh tonight and tomorrow with one of the Divine Nine fraternities, with their healthcare leaders at an event tonight, and with their plenary session with, again, the brothers. I won't say their name because I know there'll be bias in the room.
There's bias in this room. I'm just telling you. Just avoid that conversation right now. Take a left.
I just want to add one thing. Black leadership in this space and today and in this room is phenomenal, but the Black leaders that are coming behind us are ready. Yes. They are ready, and we are just trying to clear the space so they can do what they need to do, right?
You know, it's funny when we talk about health equity, I think about what we did at BDO at the beginning of the pandemic. We're talking about the pandemic, and we said, and we saw all these articles, we shut everything down, go home, everybody go home, and here's how you should work from home, right? All these articles, and here's how you should work from home. And we looked at our audience and said only 10% of our audience could work from home. They had to go back to work. They were frontline workers and had to put themselves in harm's way. So the equity that we created was we had to change the tone of the content that we were creating. We had to create the content for the people that we were reaching. And that content says, here's how you go back to work safely. And here's the information about getting vaccinated so you can return safely and feel comfortable in knowing that if you do contract COVID, that your likelihood of survival increases significantly. So it's about, so when we're talking about health equity, we're talking about tailoring that message specifically for the audience you're trying to reach. So the next question for the panel, because y'all have been fantastic, is a portion of healthcare is focused on the prevention of chronic illness. In your roles, what are you doing to help impact health equity regarding the prevention of illness?
Thank you. So that's why the Alliance for Women's Health and Prevention was created, to look at healthcare for women from a policy point of view, with an equity lens, health lens, and to look at it from the standpoint of prevention. So we're really focusing on policy relating to breast cancer, cervical cancer, colorectal cancer, osteoporosis, and vaccines from a prevention point of view. We want to step out there on prevention and make sure that women and girls are getting the right care at the right time from the right providers.
Amen.
You know, just to build on the prevention component, so we talked a lot today earlier about breast cancer and earlier lines of therapy that are happening in the community setting. But we already have 2 vaccines that prevent cancer. Mm-hmm. We have a hepatitis B vaccine, and we have an HPV preventing vaccine. HPV is an important cause of head and neck cancer, or pharyngeal cancer, cancers of the throat and the mouth, and then cervical cancer. And today we know there's data. The American Cancer Society just released data that young girls that were vaccinated in 2006, fast forward today, 17 years, and there's been a 65% drop in the risk of cervical cancer.
Say that again for everybody in the back.
I'll say it again. American Cancer Society data, 65% drop in the risk of cervical cancer today in the United States. But only 1 in 2 adolescents, I have to be careful about calling them kids, adolescents are young adults at age 13, only 1 in 2 has completed their full series for HPV. That's crazy. We have a cancer preventing vaccine, but only 1 in 2 young adults or young children at age 13 have completed their full series. What are we waiting for? And it's not just the boys, it's the girls, it's the boys as well. And that's just cervical cancer, but this is for all HPV related cancers. When we think about the United States, about 100 million people don't have access to a healthcare professional. Yet 90% of this country lives within 5 miles of a pharmacy. So you ask, what can you do? Take our young kids and our young adults, go to the pharmacy, and let's get vaccinated, because we can prevent HPV-related cancers. We can prevent hepatitis B today, now, and there's more work to be done.
This question is great, and it really made me reflect upon the great work that blackdoctor.org does in terms of promoting wellness and health, and also agencies like Melissa's. We are partnering, we're focusing on cancer and cardiovascular disease. And we're partnering because I think really all the major advancements will come with partnerships and coalitions. So we're partnering with the American Cancer Society and with the College of American Pathologists on breast and cervical cancer screenings, see, check, screen. And then on the cardiovascular front, we're focusing with American Heart Association on check, change, control initiatives. And we're starting to work with the University of Indiana on their iHeart program, which is community-based. We talked about the fraternities and sororities, getting out to the churches. I would tell you the barbershops, great place, but it's really working with those community workers, because you really have to start with hypertension and you have to look at the social referrals and the health referrals. And that's the only way I think you're going to make meaningful change on prevention.
Go ahead.
I have to give a shout out to the primary care physicians and providers all across the country. I think it is a privilege and an honor, and I think everybody deserves a primary care provider that hears them and can bring all of this wonderfulness that is in the community to them. I think it makes a difference. I think primary care is hard. I think we have to think a lot about how care is delivered. I think we have to think from a policy standpoint, because if you're in primary care, you're there because you want to be there. You recognize how important that is. But the realities of doing that in our payer model now is challenging. And until that gets fixed, we're going to have a hard time, as providers, being the best PA or nurse practitioner or physician that we really want to be and signed up to be. So, so shout out to all the PCPs who are fighting the good fight.
Absolutely.
Well, I really appreciate what BDO does to really advance awareness, because that is where it starts. I think we all also in this room are advocates, and we hope that people are advocating for themselves and their family. We've served on boards, and I'm sure all of us have experience on boards of advocating for self, advocating at the policy level, advocating at the governmental level. Reality, though, is it does get back to how do you be empowered when you are in that unempowered mode so often of healthcare, and you find yourself in a crisis and you find no one helping you through that. And you also may have family system illness kind of construct that says, well, my grandparent lost their leg, I'm going to lose my leg, I've got the same disease, this is just what happens. And so then the biases and the bullying that happens in the healthcare system then impedes progress even when people are aware and are trying to advocate. So that's where I just would always be on the platform of how do we empower ourselves, our family members, our institutions to recognize, we really need to adjust and see those different blocks and sizes that people may need and meet them at their cultural family system experience and help them get the preventative care that is life-saving.
Just to build on something Paige said, and Rashima and Ricky and team talked about it on the first panel, but just to make it even more succinct, health literacy is an important predictor of health outcomes. And we know in the Black and Latino community, outcomes are worse, 30% worse than our white peers. But health literacy is a more important predictor of health outcome than education, income, where you stay. And that's the reality. And as you've said, if we know better, we do better. So health literacy is so important for us to be able to learn and educate others and then put that into action, do something.
Absolutely. I mean, that's what we do at BDO. And we would say health equity starts at home. And at home is getting an accurate family history, that is learning about the conditions and the preventative measures that you can take in your home, because primary care physicians are great, but we only see them sometimes 15 minutes a year. What are we doing with the other 365 days? What are we doing with the other 364 days? And so health equity does start at home, and we have to take some accountability, and that's what we do. We help bolster and give that health literacy to our audience. So when they go in to see those primary care physicians, they're a better patient for you.
But I also think we need to advocate for ourselves from a policy point of view as well. You know, we can do this from a primary care point of view with making sure we get the healthcare services that we need. Everybody has a Walmart near them to go to get that access to that care. But I think what we also need to let our folks know is that policy is created through some guidelines. And that was alluded to in the earlier panel with the USPSTF. And those folks write guidelines for all of us. So all of your healthcare carriers, they look at the USPSTF's guidelines and they make a decision on what you're going to get for your healthcare.
Yeah.
Every single one of them, every carrier. And so when you look at it from that standpoint, it's for all of us to advocate. When we go back to talking about cervical cancer, USPSTF will be looking at the guidelines for cervical cancer this spring. Those guidelines come up every 5 years. And we want to make sure that we're going to have the co-testing with HPV and PAP testing to make sure that women get the best access to the best care that we can possibly get to them. So policy is definitely something that we can all put our stamp on.
Absolutely. So next, achieving healthcare can be and is a daunting task. We all have to play a role in closing the gaps. What pieces of the puzzle are you hoping to fill to create the best picture of health equity?
Can I go first? Since I actually lead a program called Close the Gap within Boston Scientific.
Well, I teed that up for you.
I know. But by no means is this meant to be owned by one entity. So that is not a patented name. That is just our commitment for the past 20 years, that we will work on closing the gap. And I do have to say that COVID made us adjust in a good way, even though it was a terrible time. But it made us adjust and move from, putting the responsibility at the patient's feet and really recognizing the biases in the systems and what needs to change in the systems. So while we had done many sporting events and barbershop and trying to meet people where they're at and handing them the information and saying, go be smarter in your doctor's office, we really are now actively working with the people who know us. So we are a medical device company. Would you know that by the name Boston Scientific? You probably, unless you know medical devices, think, well, what scientific work are they doing? What's the chemical compound that they're involved in? And so the piece of we are out in the community already. We do have organizations that already know us. Those are hospitals and healthcare systems. And they already have initiatives underway. So what do we do to meet them where they're at? But importantly, to help them improve the patient experience in the system. And so that's where we're really working on what are the disparities? How do we bring that story forward? Not so we can spend the next 2 years doing data analysis together, but more importantly, so we can hear what their community action is happening today, now being redeployed from COVID vaccinations back to the #1 killer, which is heart disease, and back to the biggest amputation epidemic, which I think is amputations in the Black community. So that's where, and I know you had a wonderful session with Dr. Faccaretti on that, but that's where we really are then trying to be different in how we meet this post or endemic world of COVID.
I will say at Cedars-Sinai, I think we've been taking a very broad approach to it. So thinking about our community interface, thinking about our researchers and what questions they ask and what questions they're not asking. But I think I'll focus my comments on what we're doing internally, looking in the mirror, right? And being able to say, maybe my baby is ugly, right? Because it's one thing to read a paper and be like, oh, those people. It's another thing to interrogate your data in a way that hospitals know how to interrogate data. They have robust quality and patient safety machines, right? But to look at that data and look and see who's being advantaged and who is being left behind. Those are hard questions to ask. And I think in my role, when we find this, and as we have found this, really asking all of the questions that are necessary, and expanding those questions to do something about it, right? So in my role, I'm just putting equity back into the quality and patient safety machine that it should have been 20 years ago, right?
I'll tell you what, COVID was a wake-up call for everyone, and I drew a lot of inspiration from Boston Scientific. I know Sam, Merck, Novartis, there are a number of companies that I think were out front. And I felt like we had to catch up. And so we decided that we were going to have impact in our community in Indianapolis and really work to build trust and build the relationships. Because while, someone said, I didn't even know Roche was we thought Lilly was the only person in Indianapolis. And so we said, we want everyone at the table, all the major healthcare providers, Eskenazi, IU, Community Health Network, a lot of the federally funded health centers, Gennesaret, HealthNet, and then, some of the social organizations like the Urban League and La Plaza. And so we said, let's get everyone together for a health summit. We identified kind of critical zip codes and areas and chronic disease states that we wanted to, work in. And the first session wasn't that productive because, like you said, everyone had their own initiatives. No one knew exactly what the other one was doing. So we brought everyone back again. And this time we said, okay, what are your top 3 priorities and what are your top 3 gaps? And that proved very, very helpful because then we could see like the alignment across the entire community and take a holistic look. And the most important thing that came out of that was the need to do a patient journey mapping with community health workers. And that's where it got real. Like it got really real at that point, because that's where you can see the practical aspects and things like you wouldn't imagine, like, transportation that came up earlier and employment, and those kinds of things where it's like, oh, like I didn't know that impacted in that way. And so we're just beginning, we're just scratching the surface, but I take a lot of inspiration from Boston Scientific, Merck, Novartis, all the key players out there, and then agencies like yours.
That's fantastic. We're understanding just something as simple as transportation could be the determinant of whether or not they show up. And on one side, you could say, oh, that patient is non-adherent. We know what that dirty word is, but it just could be they don't have transportation to get there and they want to get there. And so if we can find where those gaps are, that's how we work in health equity. So finally, I want to ask, what's the future of health equity? And what are some steps you and your organization are taking to achieve it, hopefully in our lifetime?
So maybe I can kick us off. We're doing a few things because we recognize that we can't, as Merck and company, do it by ourselves. So, what we're doing today, coalition building, bringing different constituencies together is so important. From a vaccines perspective, we recognize that misinformation was really impacting health literacy and was creating a lot of mistrust about the role of vaccination. So we partnered with social media companies because they didn't really understand how to address misinformation that was happening online. We've also convened other partners to help ensure that the right information is online and being shared in the right way. That's one. We spoke about access and that 90% of Americans live within 5 miles of a retail pharmacy where they can access a nurse practitioner or a pharmacist for routine vaccinations. So we're doing a lot of work with community pharmacy. From a clinical trial representation perspective, BDO has been involved and we want to help drive that within Merck and Company and across the industry. We've heard that throughout the 2 panel discussions today. And again, just continuing to find ways to bring information to the community in a way that the community understands through people who are able to resonate with the community. So those are we're trying to be smarter with how we engage with healthcare consumers, advocacy organizations with meaningful language, and then perhaps last but not least, diversity within our groups where we're leveraging our employee business resource groups. We have business resource groups for the Black community, the Latino community, the Asian community, veterans, women, and those are just a few examples of how we're leveraging our employees to help us communicate with the community.
One of the reasons why the Alliance for Women's Health and Prevention was created was that we realized that there was a gap in terms of health equity. And that gap for us was really relating to policy. And so we've been talking since I've only been on the job for 6 weeks. But there are tons and tons of women's organizations that are dealing with policy issues. We work with the American Cancer Society. We work with the Black Women's Health Imperative. Those are just a couple of the organizations that we have had conversations with around policy issues. But the truth of the matter is, when I think about policy, and I mentioned earlier about USPSTF, I think about our mamas, our sisters, our best friends, our partners who need to get mammogram screenings, need to get the cervical cancer screenings. And when you look at the guidelines that come out every 5 years that have an impact on our getting our health access to preventive healthcare services, you need to look at how you can collaborate with those organizations that are already on the ground. You mentioned about Divine Nine, they're already on the ground. You're going to be meeting with the brothers. The brothers need to tell their wives, their partners, their mamas, their cousins, all of that, and cooking them, exactly, about making sure that they get their mammogram screenings, make sure that they get their cervical cancer screenings and the colorectal screenings. But from a policy point of view, we want to make sure that you're having those conversations with your members of Congress. I'm real happy to let you know that we're supporting Congresswoman Sewell's legislation that she just dropped a couple of weeks ago. And that legislation is in the name of her mama. And that legislation helps to make sure that if the Roche and the Mercks of the world and everyone else have these tests for cancer, that we have those treatments, that we have those tests, and that they do get paid for. So we want to make sure that those things are available. There's a thing called Medicaid unwinding, okay? That meant that when COVID came about, 30 million people came onto the rolls for Medicaid. Those people are about to come off of the rolls because the emergency has ended. And so we want to make sure that they don't come off the rolls. We want to make sure that at the ground level, that they are getting that application, redoing that application, sending it back in so that they can be redesignated and stay on the Medicaid rolls to make sure that they get their preventive healthcare screenings. So when we're talking about gaps, there are enough organizations for us to work with that are already on the ground doing wonderful things with breast cancer, cervical cancer, colorectal cancer, vaccines, and osteoporosis. We just want to work with them from a public policy point of view.
Yeah, so I love this question because it's what is it in the future and within our lifetime, which is kind of a duality there, right? You got to manage the tension between those two. And I think our 10-year ambition is to deliver twice as many pharmaceuticals and medicines at half the cost of society, and also to deliver more access to high medical value solutions. And so we're taking a three-pronged approach. One is around women's health for breast, cervical, and Alzheimer's, and also maternal and fetal health. And this is what came up during the first panel discussion, but we're actively trying to ensure that more underrepresented females, women, are in clinical trials, because it really is about the gene. We were sharing that earlier today. And also to make sure that there are more women as serving as specialists, because that's important too, to be seen in that way. Also, we're trying to advance the scientific workforce. So we want more, Black and Hispanic PhDs in the workforce, not only for Roche, but also across the industry. And we're working with University of Maryland. We're taking a global approach, University of Nairobi, Purdue University in Indianapolis, and also ETH in Zurich. And I might just call out the University of Maryland is where Kizzy Corbett, who led the discovery of the Moderna virus, and Dr. Jerome Adams, our former Surgeon General. But it's important that we really advance more Black and Hispanic PhDs. And then finally, relative to sites, and this came up in the first panel discussion too, it used to be that clinical trials were only done in the major academic medical centers. Those need to move to the community, right? And so to do that, you have to have site coordinators, you have to have principal investigators that look like us, right? Because how do you build the trust if they don't look like us? And it's an employment opportunity for our high school students, for college students, for ready now, employment to get into the medical profession. So I know it's broad, but very pointed areas that we're looking at.
Just add at Cedars-Sinai, we think a lot about that piece of, who is providing the care to our patients. We're in Los Angeles, of course, a very diverse community. And so thinking about how are we growing physicians of color? How are we contributing? How are we growing allied health professions of color so people can have that choice and don't have to spend a whole day on a website trying to figure out where the Black doctor is or not. You shouldn't have to just search for them like that. It should be very available.
Right.
And then also from the care delivery standpoint, because we are often the point of care delivery, thinking about how to take what can be viewed as a fragmented healthcare system to give patients what they need to achieve, right? That's it. So if there's opportunities within their payers, that the patient is aware of that. If there is, something at their local Walmart or what have you, or some community sites within their community, that they're aware of that, understanding that we are often the translator of that for many. And, there's a lot out there, but it doesn't always make it to where it needs to be, right? To the point of the patient, because it can be a lot.
Well, Boston Scientific just released the performance report for 2022. And in it, Mike Mahoney, our CEO, starts out with, we put the patient, employees, and community at the center of everything we do. It's one thing to have a tagline, and then the next piece is, are you living that? And how are you living that? And I do have to say, Sam Conaway that you see on the screen there, and my boss, Camille Chang Gilmore, who's our Chief Diversity, Equity, and Inclusion Officer, are making that real. And that is why we are equipped and we are equipping our employees to be the face of change. And it does mean in the United States that we have to take on racial bias, and we have to be willing to say racism is a public health crisis. That is alarming to our colleagues internationally, and they want to say, you mean equality, and they want to change the names. And that's fine. We need to be sensitive to each community that we work in. But in the United States, I have to express that leadership message I shared at the beginning. It is our Black leadership that is making a difference in what our future looks like.
Wow, fantastic. Just as we're coming to the end here, Dr. Harris, you said the word that I always say when people ask me, what do you do, right? And they say, well, Ellis, what do you do? And I say, well, I'm a translator. I translate complicated health and wellness information to make it deliverable to an audience that needs that information the most. And everyone on this stage is translating in their own way. They're finding ways to translate what they do to the audience that needs it the most. And that really, to me, is the essence of health equity. That's what we came here to discuss today, and that's what we're going to continue to move forward into the future. talking about health equity. So thank you again to all the panelists for coming here today, as my heart is beating the past 5 minutes. And I would ask, if there's not any questions coming from the audience, I would ask that we can get, as we're about to break for lunch, everybody to stand up, just for me one moment, to stand up for me. I know, get that good stretch. All right, and can I get everybody to take one step to the right? All right, now that we've all taken a step in the right direction, let's continue that path on health equity. Thank you so much. Let's break for lunch.